That's kind of working on my diet.
Well, I
One of
had
the
the
positive.
opposite, so I'm jealous. Had the opposite. I felt like I was so hungry. I'm like, this is not supposed to work this way. I'm supposed to be. I thought I was not supposed to want to eat, not eat everything.
I'd like to welcome everybody back to Alabama Care. Today we have Dr. Eliza Belle, and Dr. Belle is the Director of the Psychological and Behavioral Services at the Alabama Department of Mental Health. Today we're going to be talking about psychological and behavioral services in the state of Alabama. At this point, I'd like to hand it over. Dr. Belle, if you would introduce yourself.
Hello, everyone. Like you said, I am the Director of Psychological and Behavioral Services for the Department of Mental Health underneath our Developmental Disabilities Division. I am a psychologist by license and trade. I began my journey with the department actually in our state hospitals and did acute inpatient work with those who had mental illness and mental and substance abuse issues, as well as our forensic arm of our and geriatric hospital as well. And so leaving that environment and coming to our developmental disabilities division, I felt like bringing some of that clinical background and perspective, as well as programmatic, where we saw a spectrum of issues from being able to be managed and supported well on one's own to needing some extensive levels of support. And what all happened in between was a great perspective to have for our ID and DD waiver supports and services that we offer through the state. So I've been
Yeah,
with our DD division now for about 5 years and work with our waiver programs.
awesome. Well, congratulations. And I'm excited that you have that experience from the hospitals before and bringing that practical experience, that one-on-one speaking with the actual individuals and able to recreate that at the administrative level. So for
Absolutely.
anyone that's kind of new to the hierarchy of ADMH and the divisions, what when I think of like individuals that are served in the community, how does the psychological and behavioral services, how do they play a part in their well-being and their continued well-being?
Okay,
Kind of
so
from the
with our
top
department, yeah, with our department, we have several arms, and our main clinical and direct services arms of the act of the whole department would include our substance abuse division, substance use disorders that are covered, as well as our MI division, which covers our mental health component, and then our DD division, which is specifically working with individuals with developmental and intellectual disabilities. And so
Mhm.
the Office of Psychological and Behavioral Services falls under our DD division. So we are a service that's specific to individuals who have intellectual disabilities and developmental disabilities. And that may include, those who have what we call ID and DD, as well as mental health conditions or substance use disorders or physical disabilities. But the dominating and the baseline population would be that someone has an ID or DD. And so within in our department, we provide behavioral services and psychological services that are specific to the needs that may emerge from that group. And those would be needs for behavioral supports and interventions that help an individual become as independent and autonomous as possible in their communities with all the skills and necessary adaptations that are needed.
Yeah, I was going to ask if we could get a specific example of what a behavioral or a psychological support is.
Sure. So when you think about it, and I use the comparison to what in a school setting, that there's a traditional curriculum offered in the school that all state offered students are to take part in as part of their curriculum when they're trying to graduate and they have a goal of graduating. Along that
Mhm.
way, through assessments, through observation, through input from a myriad of resources, whether it's family or other professionals, educators, a student may be identified as having some barriers or challenges to that ultimate goal of graduation using the traditional curriculum. That may be a deficit in a certain subject, in a certain way of communicating, handwriting, behavioral, attending to the classroom model. And when that happens and it's identified, people come together and they create what's called an IEP. It's an individualized education plan. And that plan really looks at that individual's needs and what would it take to help them reach that ultimate goal of graduation or completion or that full process of education with those challenges in mind and supported. Behavior supports are seen the exact same way. An individual may have an ultimate goal of living alone, getting a certain job or career path, having a relationship or activity that they're a part of that brings them joy, and also a full life of things that at their choosing and decision make them happy and content. And there may be some things along that path to that goal that may hinder, may weaken, or slow down the process of them reaching that ultimate goal and maintaining it. And we create what's called a behavior support plan, because there may be behaviors that emerge that are seen as barriers, or they could be seen as difficulties along the way. And they, with supporting, with intervention and with modification, can absolutely be utilized to help them then move along that path a little bit more quickly.
Would it be correct in saying, so in school you kind of have an IEP plan and you'll have some supports through there. Once you graduate out of the education system, if you're receiving a waiver and services in the state of Alabama, you will have a person-centered plan. The behavioral plan will be part of this person-centered plan if needed.
Absolutely. You got it. That's exactly right. What we call the behavior support plan as part of that ultimate person-centered plan is that if there are barriers to reaching the goals stated, because of course there are goals that are created with the individual, with their support persons, there are goals that are created in that person-centered plan that are ultimately worked towards throughout their services that they receive. And if there are barriers to achieving those goals, a behavior support plan, or for short a BSP, is created in order to help remediate those things.
Gotcha. Could you give us an example of maybe, so let's say one of my goals is to attain employment in the community, and I'm exhibiting a behavior that is restricting, that is turning my employers off. They don't want to hire me during the training process. What would that look like for myself to try and get intervention and move past that point?
Okay. So that's what we see commonly, that, working or having involvement in regular and consistent activities outside of their home. And that behavior, I'll give you an example of a behavior, it may, or two, there may be someone who is aggressive, uses physical aggression to possibly express themselves, because there may be a limited amount of communication for reaching a person or getting their needs met any other way. And if I'm able to lash out or hit or have inappropriate boundaries, which is a second kind of behavior we may see, some personal boundary issues, then at least someone is responding to me. I may not be getting ultimately what I want, but I'm getting something in that when I do this behavior, when I act this way, people respond to me. And that's ultimately what I'm trying to get to, even though how I'm doing it may not be appropriate for the setting I'm trying to maintain in, especially say in a work setting. If I'm aggressive, if I reach people by hitting them or striking them, then that won't allow me to be at work every day and attend to the things I'm supposed to. And so while for so long, it's all I know, it just may not be productive or helpful. And in that way, if someone was to help intervene and teach me ways to communicate my needs without having to hit, without having to strike out, without having to aggress to get that, then I'll have tools that allow me to then communicate effectively or productively in a work setting. So on our waiver, we have what's called positive behavior supports. It's a category in the waiver where someone could seek this service, and then there would be professionals that are behavior analysts, licensed behavior analysts, behavior technicians. We have qualified disabilities professionals that are trained to develop behavior support plans, assess behaviors, determine what the function of that behavior is. Like, what is this person looking to achieve by behaving this way? And how can we then look at other ways of getting that in a much more productive manner? And when you seek that service on the waiver, like you would any other service, whether it's personal care or transportation or personal living needs, it was positive behavior supports is the same way. You would select that service, and then that way your support coordinator or case manager would then connect you to professionals in the community that could work individually with you to help develop that plan and also help to maintain the plan as you're going through it.
Does that look like something where that professional will come to the location, to your house, the individual's house, or is it more going into the doctor's office kind of thing?
Both. So there's a couple of ways that that's done. There are some settings where behaviors analysts have offices where you can go to appointments, and in that appointment, you'll go through some targeted role playing, intervention practicing, discussion about some things, real life experiences, and then there's another component of that where that professional would come into your home and help work with that individual on a regular basis. And that might be that they're coming in to look at environmental needs that might be changed. We found that there are some behaviors that are maintained because of some settings in the environment that with a little tweak here, a little tweak there, you may see some positive reaction. And that might be lighting. It may be the way a room is situated. It may be certain items in the refrigerator or in the kitchen that can either support or cause more issue, and you may not even know it. So that behavioral professional could come into your home and help assess those things, work with the person one-on-one in the community as well as in office. It's done a lot of ways.
Yeah, it might be something that I gloss over that really frustrates somebody else, and I never would have thought about it. Like you said, the configuration of the refrigerator, simple things like that, the lighting that I wouldn't take notice to, but may have a big effect on my family member or others in the community.
Certain TV
And when we
shows, sounds, music, a lot of those things matter. And we don't know how much they matter to us as the, say, support person. But then thinking about how it could be influencing a behavioral reaction is usually tantamount to learn that.
As we were discussing there, it made me think a lot of behavior, maybe even in society at large, is because of feeling frustrated of not being heard or communication and frustrations of nobody's listening to me. Thus, I have to go to the next level in my communication. And ultimately, when you feel like nobody's listening to you or you're being disrespected, you get, a fight. Or if you're countries, you get a war.
Yep.
I feel like it really boils down to the lack of the communication there. So trying to get in before it becomes something where somebody is lashing out physically, trying to tweak these things in the home environment, in the work environment, so that that individual can be heard properly, um, and everything goes smooth there. I have a quick
Absolutely.
question from one of our audience members. Haley Nugan says, do you have a requirement to qualify for the services? Are there any requirements?
The requirement would just be that you have behaviors identified that are in need of service. And so to get positive behavior supports, one, you would just submit the reason why you're wanting the service, if and identify, and that comes through our support coordinator or your case manager, which is what we call our case managers, our support coordinators. But they would help identify what the needs are, what the barriers that have been identified in reaching the person-centered plan goals, and how long those things have been going on, or what has been attempted in the home or environment that maybe hasn't worked. And then you would just request that you have positive behavior supports to help support those things.
Yeah, so you do need to be receiving a waiver in the state of Alabama. You need to be receiving services. But once you're receiving a service and you're on either the ID, LAH, CWP, whatever that looks like, it is part of those waiver services. So if you're receiving that waiver, you need to get with your support coordinator. You need to write up, first of all, you need to document in the home or in the location the things that you're noticing
Yep.
and why you think positive behavior services would be a good thing for you or your loved one. And once you have that documentation, you're already on waivers, get with your support coordinator, hand over the documentation, and they will help you get it up to Dr. Bell, hopefully approved, and back down into your local community to find those professionals that you will work with on a weekly basis. What does that look like? Is it a weekly basis or is it more of a monthly thing?
It usually is up to that professional. There are different provider methods for how it's worked. When there's an assessment done in the beginning, that professional will kind of create a plan, and that may for some look like more targeted assistance. Some it may need look like a varied schedule of intervention. Of course, once a plan is developed, the understanding of it is that it's day to day. Everything is day to day. And so the ones who are living with the individual or others who may be involved, say whether it's a day program or someone in a church setting that might be really much more plugged into the individual, or other areas where they participate in their lives, they may even be involved in helping the plan be successful. So it's a day-to-day intervention process, but that actual professional may come in and do targeted guidance on a scheduled basis, again, ranging from very frequent to less often, depending on the individual and the actual need that's being done. We have
Yeah.
folks who, for Haley's question, if you're not a waiver recipient, positive behavior supports is a term for what is also known in the community as applied behavior analysis. It's based on those principles. It's how we view behavioral intervention, replacement of problematic behaviors, and learning of new skills, and choice making and decision making, which is an applied behavioral analysis model. And you can still seek services for applied behavior analysis through Medicaid in the community without a waiver. And so we have positive behavior supports that are a waiver service, because we create services that we believe on the waiver are what individuals may utilize and need to help be ultimately successful. But if you're not on a waiver, you could look at applied behavior analysis, ABA, through Medicaid.
And her question follow-up of what is the link to register? And I think, Haley, we need a little bit more information. If you're currently on a waiver already, she says, I have an ASD son, or if you're not receiving a waiver, that's something maybe Dr. Belle would be, would you be okay with us putting your email in the chat?
Absolutely. So if you are not receiving a waiver, then it really begins a little bit more ground zero with that, because you would need to then apply for a waiver, be approved for the waiver, and given moved into waiver services, and then you would be able to bill or request things that you would like for your son to receive. So that would be the starting point. With autism, I'm not sure if you're aware, but we also have autism services offered through Medicaid in our state, EPSDT, which is the doctor prescribed or referred program where Medicaid will ensure and provide autism specific services for individuals birth to 21. So you can then also apply for EPSDT services. It's not a waiver, but through Autism Services, there is intensive care coordination, in-home supports that would include behavioral services as well. So there's a couple of routes that you would go. Our waiver is specific to those who have intellectual disability, or ID. So if there's not ID present, then overall that individual would not be eligible for the waiver, but there are some autism supports as well offered through our state.
Yeah, so it sounds like, Haley, depending on where you are, where your son is, there are a few different factors there that can help out, pretty pretty next week or this month, pretty close here. You mentioned ABA. I've spoken with individuals who have received that service, and as they've gotten older, it's been kind of a controversial thing for them. Some say it's really helped, some say it didn't help as much. What are your thoughts behind some of that?
I understand the not help or help, because I think it goes a various amount of ways. We see this transition period that happens usually when an individual is moving from a school or structured setting to a much more independent lifestyle. And when I say independent, I mean independent of these commonly known structures like a school, like a work setting that may have been designed for a young person, or where there were more resources available at the school age than are after the age of 25 or 21, really moving up into the early 30s. There's this period where I'm used to, even if I'm not, ultimately achieving the goals of adulthood, because I'm going to eventually move into that time frame, I do have these things in place that keep me structured, keep me guided. They're almost an automatic support plan because it's routine oriented. I have a parent that's, basically providing for everything that I do, and I don't have to question much because I'm just used to an automatic sense. When that shifts, we see some changes. And those changes become that reaction that you mentioned, that kind of, I can't communicate it, but something's happening with me and I don't know what's going on. So I may aggress. I may have a confusing relationship with people where I don't know that boundary so much. I may not know how to express sexual feelings in a way that the society thinks are appropriate. So I'm acting in personal boundary issues, and so that age comes into place, but also that period of time where I'm moving out of structure into my own almost forced independence that life gives us, and not a lot of resources that come with adulthood, and that's unfortunate. And so sometimes that model of reward and direct, where I'm every day, if I'm a teacher, I can say, I can stop every 5 minutes and give you reinforcement and reward and tokens and things that might be helpful for your structural understanding of things. But when I'm in the community and I'm now 25 years old and I may live in a home or live with my parent who works, and I'm here and I'm taking care of, things here at the house, I don't have someone that's readily giving these assignments and rewards and things that, may or may not influence me the same way. And so
Yep.
it's, in my mind, I think that it's not that behavior analysis doesn't apply at a transition age or an older age. It just needs to be readjusted. Our understanding of now that I'm in this point of my life, the way I communicate it may not be so easily understood as it was when I was a child or when I was younger. And now I need a little bit more eyes on me to figure out that I am hitting you, but I also really want to be your friend, or I really want to receive just a normal amount of attention and affirmation, but I'm doing that in ways by breaking things in my room or tearing up things, and I'm because I don't know else how to get it. It's not just and because those behaviors become a little bit more problematic when we're older. We're stronger, we're taller, we are more forceful, and we're more purposeful, and those things can be hard for a caregiver to manage, more so when we were a child.
Yeah, and I think a lot of people could talk about that in some capacity from their experience going from high school to whatever level they went to next. I know for myself,
Absolutely.
I went into college and young 18 years old, and you don't have that. You have to be home at midnight or 10 o'clock anymore. So you have a lot less rules and structure there, and a lot of people go through uncertainty there. And where do I fit into this new environment? I know for
Hmm.
myself, I was very fortunate that I was part of the wrestling team. And so I went right from the high school wrestling to the college wrestling. And that really helped me form, that I had to get up at 6 o'clock and go work out. I had to do those types of things. And that
Yep.
helped my transition there. I think that our transition has gotten better going from high school to college, especially in the disability community. But there are certain things in the past, like for my family member, she was in Partlow for a number of years, 20 years, and then they kind of shut that down. And there was, from my understanding at that time, there wasn't like a gradual, we're going to transition you in and work on these things. So that's where your work has come in with some of those CSS teams and
Yes.
placement and things like that for those that maybe are older than the K to 12 and transitioning out and didn't have that opportunity at that time. So you offer those services as well.
Yes. So we had part loads and we had regional facilities where individuals may have spent a long time, and they were adults, they were older, or they may have moved from adolescence into adulthood in a facility. And when they were closed, you're absolutely right. The idea was we don't need this type of setup to offer an individual who has a need. We need to be supporting them in the way that anyone else should, which is their right to have independence, freedom, and autonomy. So the idea was that we would close them and then in favor of a community setting, which was amazing. That was an amazing idea, design, and plan. The transition, I think, was harder to understand because we were saying this setting isn't working. Let's quickly get someone out of here and get them where they belong, which is in a community setting. But then the movement there was where we saw some of the issues emerge. Because when you have someone, again, that same kind of idea of structure, even though the institution may not have been the appropriate place, the structure was a now ingrained into that person's lifestyle, the day-to-day, the meals, the schedule, the ups and downs, the type of staff around you. And so to go from that to then now you're in a small, maybe maintained group home, or you're back with an aunt or an uncle or a parent when you weren't in that setting before, it could have been very traumatic. And it was for many individuals. And so what we
Yeah.
created at that time was the idea that there should be this hand off, like a warm hand transition where I'm going to walk with you out of this facility into the next step with guidance. And so we created comprehensive support services teams in our regions that had facilities where there were behavioral staff, background in behavioral services and developmental behavior that worked for the department, who would then be identified to serve specific individuals who may have had a little bit more of a need for that guidance, a little bit more difficult transition out of that facility setting. And so we still maintain that model, but even though we're so far out from the facilities, we now function as that same type of guidance, but with consultation purposes. So we have teams that if there is someone receiving positive behavior supports in the community, then by a behavior professional, our CSS teams could still be called if there are some difficulties with that plan, with that process. There's some things that have been tried, some stuff that has been consistently done that just isn't working. We have teams that can come in and work with that professional to help maybe give additional ear, additional input, additional feedback. And we also have contract doctors that perform psychological or telepsychiatric clinics and behavioral clinics twice a month, where if someone has needs for psychiatric care and maybe experiencing difficulty accessing that in the community, or if they have medical conditions that are influencing their behavior. We don't talk about it a lot, but pain is a huge influencer of behavior and usually problematic behavior. And they're not getting that treatment or that certain perspective seen for what it is in their primary care environment. We have a medical provider, we have a psychiatrist and a dentist, which that's another area where we see some issues that are coming in our population where dentists may not be aware that certain types of methods and tools and lighting can affect someone's dental appointment experience, that just with little tweaks here, a little modification here, that person can attend to those appointments in a much better way. And so we have those doctors who on case by case will see someone who is having that those issues emerge, but difficulty with getting that done in the community. So we're that consultative arm of the department where we provide consultation and supports on top of what's being provided in the community.
Gotcha. Thank you for answering that. As I mentioned CSS there, CC Perry says, what is CSS? All the acronyms from ADMH are overwhelming. And there
I
are quite a few
know.
acronyms.
I know. And I actually thought that when I came, that I would help to minimize the acronyms. But in the process of that, when I think about any like state funded services, there's just so many acronyms and we can't get away from them. But CSS, and I'll try to do a better job of not contributing to the acronym confusion, but it's comprehensive support services teams. We call those CSS teams. They am comprehensive because we did have that psychiatrist, that medical doctor, or the primary care doctor and the dentist that would provide services, as well as behavioral staff, almost like a treatment team model that we provide in the case that someone has exceptional needs above what is being provided in the community on the waiver.
That sounds similar to what is starting up at University of UAB is the STEP clinic for those that are transitioning. They're trying to get the STEP clinic is focused on healthcare transitioning from pediatric to adult, and that can be very worrisome and hard to navigate for individuals receiving services. And so they're trying to kind of consolidate some of those things there. You mentioned dental and dentistry. Why do we not have dental with Medicaid?
Now, that's a good question. And I actually ask, as part of our work in our CSS or Comprehensive Support Services teams, some of our work, it becomes advocacy. And it's identifying where we're seeing the issues. And one of the issues, and we also have issues with psychiatry services being covered by Medicaid as well, but dental for sure has been one of those areas where we can't even get to the issue of them being able to attend to an appointment with the dentist because they can't even get coverage at the dentist. And so while I don't have the answers for why we don't have it, we are consistently going to our legislation about it. And so is one of the areas where, of course, we need coverage. We need expansion in a lot of areas, but I know that dental is one of those things that we see in our population where dental care may have been neglected in some settings, especially if they were in an institution for long periods of time, or because they cannot communicate. Someone may have communicating a pain issue or a dental issue, and so it may have gone unnoticed, and that may have resulted in a larger issue that emerged later on and needed care, and then that barrier becomes in not being able to get that care. So we're fighting for it. I don't know why we don't have it. It's one thing that we have acknowledged and documented as very much needed.
Yeah, please keep fighting for that and advocating for it. And it makes sense because you mentioned that a lot of behavioral things can come from pain. And one of the worst pains I've ever felt is in my teeth. You know,
Absolutely.
if you've got need a root canal done, that is definitely going to affect your day and how I communicate with people around me. And just imagine if, I was nonverbal and nobody was paying attention to me and I had all of this pain going on, I would definitely be acting out. Um, and then
When
they
we
also
provide
talk about,
behavior support consultation, one of the first things we do is rule out pain. And I could tell you so many success stories about when pain was mediated, how much things improved just from that. And we don't give it the credit that we should. But so we always start there. Let's rule out: is there any medical condition going on in this person's life, and start there. And especially pain. I think about headaches, migraines, and then toothaches and any other body pain where having someone then keep you going through activities when you're hurting, or lighting that can, you think about that headache that where the light's bright and it just makes it even worse and you just want to shut down and ball up and not talk to anybody. Or if someone's, constantly talking to you when you're hurting, you may want to strike out just from reaction, or pain can make you strike out. And so those things, if untreated, can get worse and worse and worse. Think about even, and this is maybe, a little TMI, but like bowel obstruction or constipation, and how
yeah,
much that can cause someone's day to be just a mess, grumpy and unhappy and frustrated. And if you can't communicate that you're having stomach issues or that you're constipated and you act a certain way, someone may respond to you by how you're acting and not by what's wrong. And then you're never getting the issue treated.
yeah, that's so true. And something that we need to pay attention to. So my family member, one of the big things is bowel movements. If she doesn't have a bowel movement for, 2 days, something's going up and she will definitely act out. She
Yeah.
needs assistance walking, but her strength when she walks goes down if she doesn't have a bowel movement. So we try and, we
Mhm.
document every day. Did she have a bowel movement? How did that go? And if not, we're always increasing the Miralax, or we'll do some other things to make sure that we
Absolutely.
get both on track, but you got to be aware of those things. I'd like to acknowledge chat here again. Haley says, we have been on the waiting list for reevaluation for behavioral development for a long time in Birmingham. Do you know where we could go to have that done? So I'm not quite sure if Haley, if you're trying to get on the waiver. I know there's a little bit of backup with the CWP going on right now. Hopefully that gets taken care of, but you can always call ADMH, and we'll go ahead and put that number and link here in chat. Clifton, if you wouldn't mind doing that for us, I appreciate it.
Sure. And
Um,
and like you said, you can email me too if your questions related to their receiving a waiting list in the community to be evaluated is not necessarily within our purview, but we could assist if there's a need for an evaluation for waiver services, or if you're saying that maybe through autism you're waiting to be evaluated for that. I just need to know more information, but I would love to try to direct you in the right way.
yeah, so Haley, Leslie, and Cece, we will definitely I'll put Dr. Bell's email in the chat here. Leslie Speakman says my daughter's in the step clinic. Great things about this step clinic, Mrs. Speakman. Leslie Speakman also says my daughter has epilepsy and intellectual disabilities, and we can't get eye care every other year. I'm not too familiar with eye care. That's
I'm not
something that I've
either.
never had experience with my family member. I know there are some gaps. such as the dental things like that we're trying to get taken care of. And I think that comes back to a lot of advocacy by individuals and everybody in the community there. CC Perry, any tips on how those of us with disabilities can try to be better advocates with our legislators? Great question, CC.
That's a great question. And honestly, a good starting place is the department. We have a legislative liaison that helps us to understand what is going on, what's being presented, what's discussed. And honestly, there are some legislation trainings and different sessions that are held for individuals that want to be advocates. I know for myself, as a mental health advocate, as a clinical advocate, as one who advocates daily for all persons to receive whatever they need to be successful and content in their lives, I had to have a lot of information and work on how do I then communicate that to those who are making legal and government decisions on our behalves for those things, because I didn't know how to access a legislative representative, or how to go on the Hill and campaign. And so you may not have to do those things, but being able to know how to write a letter, and who does it go to, who is my person, where does it go once I write this, or can someone help me write a letter, and what does it need to say, what do I want to be different? So you start with saying, I believe in something, and what is it that I believe in, and what does that mean? So if I believe in there needing to be dental services covered by my Medicaid insurance, then that's what I'm going to write about. I need dental insurance. I need dental coverage, and I need it to be where I can access it around my community and around my life. And so you may have a thing you're passionate about. And so it starts with identifying that. What is it that you're passionate about? What do you want to see differently done, or what's not happening that needs to happen? And then finding out who it is that needs to be that communicated to. So I would, again, see my email below, but I can help guide in the right direction and what that process will look like. But it starts with, again, identifying the issue, being able to find a way to communicate that. Some do, a video, a call to your representatives, a letter to legislation, going to those meetings that they're having that are public and hearing what they're talking about and finding out how to get on that agenda.
Yeah, I feel like sometimes it can feel overwhelming.
Very much
But
so.
you remember these representatives, they represent you, and they are here to do that successfully. And I think a lot of times we can get frustrated with, well, my representative doesn't know anything. They're not familiar with these things, but it's our duty to educate them. They may not have the same son, daughter, loved one, family member, and they don't have those same experiences. And so it's our
Right.
duty to try and educate them so that they have the ammo when they go down to Montgomery to really use that in legislative decision making. And
Yeah,
the
you're
other
right.
tip I heard was make don't put all the weight, all your eggs in one basket kind of thing. Make a relationship with your representative over time. Don't go and sort of throw up on them at their desk in their office. Send that letter, send an email, get to know the person. They're our neighbors. They're good people. I don't think anybody wakes up thinking I want to do harm to the community that I serve, but it takes a little bit of relationship building and education to get them there, and that's a process.
Absolutely.
Clifton, thank you for putting Dr. Bell's email in there. I appreciate that. Let me just comb through here. Optometry care is better than dental, but still falls short. CC Perry. Leslie Speaker says, can't get an eye exam every other year. Can't get her any glasses unless it's out of pocket. So that's all new to me. I don't have experience there. I'm
And that's
with the optometry.
unfortunate.
Yeah. CC Perry, how are those training sessions and the contact info for legislative liaison communicated out to stakeholders, users, services in the community? I'd love to attend. So there is a partners in policymaking that is very powerful through the DD network.
Hmm.
We had the opportunity to do all their audio and video this past year. You can go, if you type in UAB, Partners in Policymaking Alabama, maybe Clifton can put that in there. I think they start up again in September. It's a great course. It's about 7 months long, I think, and it is for individuals, family members, and stakeholders in the community. But Clifton, I think it's
Thank
just
you
a
for that.
UAB.
Yeah,
Yeah,
I was going to say thank you for that. Yeah, that's a great resource.
I think, Clifton, if you find that link, it's UAB PIPA. It should pull up something. Okay. As we kind of come to a close here, I have a few additional questions here. How about the number of individuals receiving a waiver also receive positive behavioral supports in their plan?
So we've seen that about half, it's usually about half and half. So about 50% of our waiver recipients also receive some form of positive behavior supports, even if it's for a short time or for a longer extended time. We have seen that there are those who may require or may benefit from a plan at some point.
Hmm. It makes sense to me. And then how about this is a new thing. I feel like we went from the partlows, the institutions, down to the providers, the group homes, and now we're making a transition into our own homes and living with our family or having our own, apartment or house, whatever that looks like. Is
Yeah.
there any data on um, those that have positive behavioral supports in their person center plan that are receiving services in a group home versus their own home?
So that was a little harder to gather, but we do have information. We can find that for you. It would have to be at a later time. But I do know that what I will say is that there's some barriers, and I will tell you this because there are providers that are in group homes that have access to behavioral staff that can work for the complete provider. And in that
Hmm.
way, say if someone's works for a provider agency and they are a behavior analyst and they are that provider's behavior analyst, and that provider say has 4 group homes that has maybe out of that 4 group homes, 6 individuals that need behavior support plans and need behavioral modification and supports ongoing. That BCBA can then take on those individuals, work within that provider's, their operational standards, their guidelines, their structure, and see people regularly within that radius of provider. We
Hmm.
have, though, in the living at home setting, it takes a parent or a support person for this individual to have an individual behavior analyst that is just for them. And typically, we have these folks who are independent providers in their own practices in the community, and many of them may see those under 21 because they are taught and brought up in a child and adolescent and teenager a model or childhood model, and so may not work as much with adults. Or there may be where there's a wait because their client caseload is so full that they cannot take on individual clients. And so there's a little bit of a barrier we see where it may not represent the needs of, say, someone living at home. Because absolutely, we see behavioral issues emerge more in settings where there are less eyes on, less people involved. When you're in a group home, you have multiple staff, medical staff, directors, administrative staff that are with you who can pick up on things a little bit more quickly, respond more quickly. But if it's just me and my child at home and there's some things emerging, and I also am not there all the time in a group home, someone's there 24 hours, so I might not be there all the time. It may be hard to pick up and to modify and to support. So the numbers represent typically a barrier in getting the services activated because of, say, that maybe a wait list for someone taking on a new person, or being able to find behavior analysts that see adults, or finding someone that has opportunity to, say, come in the home versus office. So it's usually a various things, and we're working with that as well. We've been meeting with the behavior analyst board as well as working with Medicaid to help identify easier access and capacity for in-home supports for our waiver.
Yeah, I think as it seems like more waivers coming down from the federal government and more HCBS compliant stuff is going more toward community living. This is going to be something that we'll see more of. Is kind of
Yes, absolutely. And we've identified that as a need, have even looked at bringing in providers that have that service offered directly for that in-home support specifically, especially with our community waiver program, which is largely a non-residential program. So for that reason, everything needs to be accessible, available, and beneficial to that person in their current setting. So that's why we're looking at some targeted, I'm talking about quickly, providers that can come in and help offer this service so no one will have to wait or seek it.
yeah. And you were mentioning kind of having eyes around. It made me think of pack mentality. I notice if I'm by myself for too long, I probably tend not to go to the gym as often.
Yeah.
I probably tend not to do these other things, and I let myself go a little bit. So it is important, even if you're living at your own home, or your own apartment, whatever that looks like, to be a part of these other groups that are in the community that kind of hold you
Yeah,
accountable a little bit, and that pack mentality there. That's
it
important.
does.
CC Perry says, thank you. This is awesome info. Appreciate you. And everybody that is watching and in chat, I appreciate you guys asking questions. As we come to a close here, Dr. Belle, is there anything that we haven't talked about that you think an individual or a family member could really benefit from hearing?
Sure. One of the things I think to end would be just the resource part of it, and that there may be some things that you're not, if it's technicality on a waiver, or you're on or off a waiver, or you've gotten to a setting where you need certain things that may not be provided through Medicaid. We still want to be a resource for you. I think that we're all, like you mentioned about the representatives, but we're all here because we believe in the work that's being done, the work that's needed, and being able to help individuals achieve what they're needing to achieve. And so we have, through our office, my office offers training. And the pandemic, when I think about the upside to, if there is any, to pandemic, was that we had the ability to offer virtual options of things that were typically offered in person only, took a long time to schedule, and had to be spaced out. We offer a virtual training series every month. Our comprehensive support services team members all take on different topics at the request of our families, of our providers, of our support coordinators, of our individuals with lived experience. If there's things that you want to be covered that could be beneficial to you on a platform like a training session or a virtual discussion, we're more than happy to offer that, waiver or not. So if you are interested in that, if you go on the site, our DMH site, you may see some past schedules of virtual trainings for the last couple of months. But moving forward, we have scheduled trainings every month, and all the topics come from our providers, families, and individuals. So if we have some topics that you wanted to talk about, if it is about that, dental services or even advocacy. I mean, I know that, we're a behavioral service department, but if there are things about wanting to focus on some advocacy things or just getting the discussion started on what you're passionate about, we can train on that too. We're open to that. And because we can do it virtually, it allows for us to reach it again more quickly, reach more people, and we are open to having more targeted discussions as well. So we have a training series that I wanted to make sure you were aware of. And if you have questions about things that can be offered, handouts, videos, things that maybe I or my staff could help to send you, provide you as you're starting to understand behavioral issues or needs or ongoing things, we're happy to do that as well.
About how many participants do you have? Because I saw the list there. It was, I think, a June list. It's pretty cool, the Zooms that you guys are doing, the virtual trainings there. About how many participants do you have in those?
We've had as little as 15 on a training up to 250. Of course, yeah, it depends on the topic. So sometimes some topics are hotter than others, and that hotter usually means I'm dealing with this right now and I need some input and some help. And even with the larger ones, what I always try to do in the larger trainings is say, this is a large setting and we're promoting, we're presenting it in a way where it's the information, it's tools, but we have definitely room to take from here. If you leave this session today and have questions about your specific situation, we bring up cases on the discussion, we bring up examples during the training. But if you have more needs past today, we're more than welcome to kind of boil it down, get a smaller group. We have a group of parents, a group of families that want to get together and train. We do that as well. So we kind of use it as a starting place and then go from there. But sometimes we've had a large groups.
Love to rebroadcast some of that, but I know it's a closed off Zoom meeting.
What we do, what we have started, and it's a good thing you brought that up, because what we have started in this next quarter has been recording the trainings and making them available on our website. So we didn't do that before, only because this has been all a transitional process. We used to, again, scheduling it in the regional office and having a flyer go out and, having an all day thing where people came, we had lunch and all that kind of stuff. And now we can offer these, whether it's 30 minutes, an hour long, 2 hour long trainings, depending on the topic or need. And you can just click on whenever you can. So we started there, but we are moving now towards recording the sessions, even pre-recording them for being able to put online. That way you can still have the information. You may not have the back and forth discussion and the ongoing chat, but you will have the information, and that could be a good starting place for you.
Yeah, I can see like a psychological and behavioral services YouTube page where you have everything
We're
there.
getting there, but thank you for putting that out there. That was an idea as well, like putting all of it. We even want to do role playing videos. We used to do that years ago. If anybody knew our department, and you may be on now, who may have been with us years ago, we had staff that would do, we would film video in our offices and create videos of examples of interventions and behavioral techniques and how, to respond to things and how to communicate and planned ignoring, how to ignore certain behaviors that aren't, or we call junk behaviors or important behaviors or things like that. We've done that. And so to put them out now would be more of, it would be basically satire because they are so old. And it may not be taken the way that they're intended, but we want to do some new videos too to be able to put on the webpage as well.
Yeah, I really benefit from seeing the modeling. I have to see somebody
Yeah,
do
me
the
too.
modeling, and then I kind of the kinesthetic value of it. I can do
Hmm.
myself, but if I see them do it, then I can do it. There, it's a big help for me.
Same here. I'm the same way.
Well, Dr. Bell, I really appreciate your time today and
Yeah.
teaching me. This is something new that I was unfamiliar with, and I always appreciate learning new things. So thank you very much.
Thank you. I'm glad we were able to do this today. And I think that, again, if anything, it sparks a discussion for those who may not have known. Like you said, this may not have been, you may have set the stage, but you may have more questions. It helps to open the door for us to talk about this past the point.
Yeah, I agree. So, chat, now that you have Dr. Bell's email, go all out. Send her all the questions. Once again, thank you. And we'll go ahead and kind of give our cameras a little wave. And we will say we're actually live tomorrow. So, we'll see you guys tomorrow. Thanks again, Dr. Bell.
Thank you.
And then you can just exit out of the window up top and it'll take you out of the meeting.